today, which is fetal alcohol spectrum disorder. So we're going to go over quickly what that is and then why it is relevant to your cases that you're talking about. So this is a definition from Canada. Fetal alcohol spectrum disorder is a lifelong disability that affects the brain and body of people who are exposed to alcohol in the womb. Each person with FASD has both strengths and challenges and will need special supports to help them succeed with many different parts of their daily lives. So that's their general definition that they just put out. I think Canada's far and above. They do a much better job than we do with handling this stuff, but we're working on it. So in Ohio, we have a FASD steering committee that works on improving like people's knowledge of the disability, and we have regional trainings that are going out. So Ohio has said that our slogan is "No amount is safe," and so we're trying to encourage women to stop drinking as soon as they know that they're pregnant, and versus thinking that if you've had any amount of alcohol that it does the same amount of damage as a lot of alcohol. So something that's interesting to note, because so often we talk about drugs in relation to using in utero, is of all the substances of abuse, including cocaine, heroin, and marijuana, alcohol produces by far the most serious neurobehavioral effects in the fetus. I did not know that. So I am a caregiver. I'm a foster parent. I've been a foster parent for 3+ years. And I have 2 children in my home who have FASD. I've never tried to get pregnant, so I don't know much about that life, but like I was so shocked when I learned this. I definitely grew up thinking that drugs were a greater risk than alcohol. That was kind of the message that we got. So now if we're looking at this in relation to DD, and these are different types of disabilities, but Down syndrome, I'm working with the Down Syndrome Society of Greater Cincinnati. They're awesome. Down syndrome affects 0.14% of the population nationally. Tourette's is 0.6% of the population nationally. Autism is 1.5%. That's a neurobehavioral disorder that we know a lot about. Like, it's very common. We have a lot of resources for. We can have conversations about this. NAS, which is neonatal abstinence syndrome, children that are born with symptoms of addiction to drugs in utero, is at 0.65% nationally. The number is a lot higher in Ohio in general, but definitely in Southwest Ohio where I am. But that's the national number. And then FASDs affect 5% of the population. That number is astronomical. If we're looking at just Ohio, 5% of Ohio's population is over 500,000 people. So this is a disability that we don't talk about very often. A lot of us don't know anything about. There are no resources for, but especially when we're talking about multi-system use, a lot of the individuals that you're looking at are likely affected by prenatal alcohol exposure, but it's not reported and we don't know what to do with it. So we're kind of in a limbo right here of what the next steps are. So I'm going to talk a little bit about what, if you're looking at a kid that has prenatal alcohol exposure, what kind of things you might see. So primary behavioral characteristics these are things that, because the brain was altered due to alcohol consumption, these things are different. So it is core to how the brain operates versus the secondary and tertiary characteristics that we'll talk about in a minute. So dysmaturity is very important to say this way and not immaturity. Immaturity is like a kid is kind of working up to, I'm going to be as mature as my peers. Dysmaturity is like there's a significant gap, and if they do catch up, it will be years. So we often say that children with FASD are about half of their chronological age developmentally. It's not always the case, but it is oftentimes the case. They have a slow processing pace. We say our kids are 10-minute kids in a 10-second world. Very impulsive and easily distractible, which is things that we associate with ADHD. So many of our kids are misdiagnosed with ADHD. Memory problems. Usually their long-term memory is excellent, but their short-term memory is really challenged. And so that's really hard when you're in school or even when you're just parenting. It can look like ODD if you tell a kid to do X, Y, and Z and they don't because they can't remember what you said. They can have difficulty generalizing ideas, making association between 2 ideas, understanding abstract concepts. So like idioms and metaphors can be really challenging for our kids. They can have challenges with cause and effect. I was talking to a family the other day. They said her daughter would fall off the sofa, get upset, get hurt, cry. They'd be like, don't get on the, don't fall off the sofa again. And she would just keep doing it over and over again. She's like, it's like she's not learning. And she may not be.
See y'all.
See you later.
Sensory processing disorder, which is something that we're seeing in a lot of kids, and I think we're doing a great job addressing it in some ways, but the causal factor of some of it we're not really sure about, and in this case the causal factor could be alcohol exposure. And then poor regulation, like mood regulation. So like, you know, all conditions are fine, there's no triggers, we're in a totally calm environment, no sensory overload, and then we just are flying off. So affect regulation is one of the things. And then of course we've got to talk about strengths. Like I know a lot of children with FASD and they're wonderful people and they have like usually like interests that they're really good at. Like one of my sons really loves music and the other one really loves art, and like that's their thing and they love that, and they're usually very gregarious and helpful. These kind of things that when we're talking about kind of their worst days in a meeting like this, we kind of forget about stuff like that. So, and then secondary behavioral characteristics, these are things that happen that because we have not identified the primary characteristics, or just because we live in a neurotypical world and our kids are not neurotypical, then these things may happen. So our kids' brains have to work so much harder to do things that we would consider pretty typical. So they'll be fatigued, anxious and fearful. They can't predict what's next because they don't really understand how the world's working. Maybe rigid, resistant, argumentative, because they are very literal and they know how things are supposed to go. If those things are different, then I'm going to argue with you. They may get overwhelmed, shut down, may have a poor self-concept, or they may have self-aggrandizement in that they think that they're the best person to walk the face of the earth. They may have maybe isolated, have a few friends, get picked on, act out in aggression. We'll talk about that in a minute, why that's common. Be suspended, sexual inappropriateness, which we often associate with sexual abuse. But if you think about lack of social awareness, impulsivity, then you could kind of get in a situation where I can't read that the other kid's uncomfortable, and so I'm doing something and I'm impulsive and I don't know that I shouldn't be doing this. So that could be the cause of sexual inappropriateness. Truancy, running away, and depression. Then we look at tertiary behavioral characteristics, which are even broader, and these things are happen because we do not recognize the disability, and we are not advocating for other people to recognize the disability. So if you think about it, so I was in the Navy, and if I asked all of you guys to put you on a ship and I said, you need to get yourself across the Atlantic, okay? You got 2 weeks, here's your charts, figure it out. You'd be like, no, thank you, I don't want to do this. Well, what if I just came in and yelled at you like every hour on the hour about how you weren't doing it right? Like, what is wrong with you that you can't get yourself across the Atlantic? It's not hard. This is what we do with our kids with disabilities, that we're expecting that they can do these things. They are incapable of doing these things, and we just kind of yell at them until we think they're going to get it done. So if we do that, and whether it's at home or at school, because oftentimes we could be doing right things at home and school is still not a safe place, then we can look at things like delinquency, having trouble at home. Alcohol and drug related problems can happen both because the children have the genetic predisposition for addictions, but also because of like how hard it is to manage life when your brain is different, when you have executive functioning challenges. So what we want to do is prevent us getting to tertiary behavioral characteristics. And then these are 10 neurocognitive domains. I'm going to bring them all up now. This is how Canada does their diagnostic procedure, which I love. This is so much more simple than how we do it in the US. But it also, I think, helps kind of clarify what we're looking at as far as what our kids are struggling with. So I just mentioned executive functioning, which many of you guys are social workers and doctors and all that stuff, so you know what executive functioning is, but managing your life. And if you think about not being great at executive functioning and then sending someone off to live independently, they may not do a great job at that and may end up homeless. Or if you're in school, they could have a high IQ, but their executive functioning isn't good, so they can't keep track of their work. Attention span, social cognition, reading facial expressions, like getting a feel for the room. They're not usually that great at that. Language, receptive and expressive. Oftentimes our kids have great expressive language, but they don't understand what people are saying. So they can repeat back to you and they sound like, whoa, Johnny really understands what I'm saying, but really Johnny does not understand what I'm saying. We talked about memory, motor skills. This can be a combination of fine motor skills and gross motor skills that are having challenges, but it's very child dependent. neuroanatomy, neurophysiology. So there are birth defects that can happen due to alcohol exposure. The most common one is hearing issues, also vision issues, but there are other things like heart murmurs and a lot of other like limb deformations, a lot of big things that you don't necessarily see as all being together. Seizures are very common with FASD. Cognition. So if you notice, cognition is one of 10 of these things. So if we're talking about IQ and someone has a high IQ, they can still have FASD. And I think it's very common when we think about what you're probably used to hearing about as fetal alcohol syndrome. We're thinking, no, these kids can't be smart, but they in fact can and oftentimes are. All of these things obviously contribute to challenging academic achievement, and then affect regulation or mood regulation we talked about, they can just fly off the handle. I too have a cold, Matt, so I empathize. Okay, so how is this identified? So these are the different things that I hear from families when I'm talking to them. So I talk to a lot of foster families, and it's estimated that 70% of kids in foster care are affected by fetal alcohol spectrum disorders. And so when I'm talking to families about having kids that they like, or like I'm thinking about disrupting them, is usually the kind of conversation that we're having. As I dig down into the cause, it's often a developmental disability. Like I can see that because I'm used to looking for that. But when you're a parent, you're just like, they never do what I say, you know, like you're so exhausted from trying to make it all work. And if you don't know the cause, then it's really hard to have empathy. So I'll hear they don't do what I ask them to. They're always playing when I ask them to do chores or homework. The littlest change in our routine can set them off for the day. We keep trying different ADHD meds and they still can't focus. If you think about it, ADHD meds fix a certain part of your brain. And if it's not that part of your brain that's leading to lack of focus, that could be not necessarily fix it. So for me, for my kids, ADHD meds don't do anything. They used to know how to brush their teeth and now they won't. Our kids can lose skills. They can, like my kids knew how to dry, when my son knew how to dry his hands and now he doesn't, and we have to remind him every time. We've retaught hand washing many times. It's a skill they have and then they lose it. They're always lying, even when I prove to them that I know the truth. And that is confabulation. If you have a gap in your short-term memory, you'll fill it in with a story, like not intentionally. This is totally like your brain just does it automatically. And so kids will look like they're lying when they really, like, this is how they remember the past. It's kind of sad. And then a really common one I hear is people tell me that they have autism, but that doesn't fit. And it's because some of the social characteristics and how the brain works, executive functioning challenges, all of those things can look like autism. But the causal factor is different and a lot of the symptoms are different. And so if we hear autism and we're like, but maybe there's something else, maybe they are connection seeking, maybe we want to consider FASD. Ah! Sorry, my screen sharing stopped all of a sudden. Okay, I can talk and bring that up simultaneously. So what I was going to show you next was the different diagnoses for FASDs. And the different diagnoses are, so FASD is an umbrella term, right? So there are 3 big categories underneath the umbrella term, and most of you guys are probably most familiar with FAS, fetal alcohol syndrome. That was established in 1973 as a diagnosis, and so most people know about that. FAS is one of, I think I have it back up. FAS is one of several diagnoses now, and the reason that that's relevant, can you see my screen? Yes, can you see my screen now? Yep, okay, good. So the reason that that's relevant is because historically we have diagnosed kids just based on their facial features. But what we know now is that facial features are only present in 10 to 20% of kids. And facial features are only obtained when the mom drinks during certain days of pregnancy. And so it's not necessarily indicative of how bad the brain damage is. And so very often we say, oh, they have FAS, it's really bad because of the facial features. But kids can have 0 facial features and they can have really significant challenges. And also we're finding that kids can be born without facial features, develop them later, and they can go away by adolescence. And so it's like this small window of time when we can even see the facial features. And really it doesn't mean anything in relation to the brain damage. So we need to be better at identifying it when there are no facial features present. But these are the different kind of diagnoses that you can get. FAS is all of the facial features and all the brain damage. PFAS, partial FAS, is all the brain damage and some of the facial features. And then ARND, ARBB are medical diagnoses for all of the brain damage and none of the facial features in kind of different ways. And then NDPAE is a new diagnosis in the back of the DSM for all of the brain damage and none of the facial features.
Hey, Aubrey, I want to let you know that we're pushing up on our 15 minutes here.
Okay.
Thanks.
So I think the next thing, I'll just go over these next 2 slides because they're about from a professional standpoint. So this is how to have a conversation with families if you suspect that FASD is involved. So this is from the American Academy of Pediatrics. And they have written this document that kind of explains how to talk about FASD as to it's like not anyone's fault kind of thing, because it's obviously a very sensitive subject because we have a causal factor for FASD versus autism where we don't know what causes it. So this is a document that you can get on the American Academy of Pediatrics FASD Toolkit. It's a good resource. And then just to go over real quick how you get a diagnosis for something like this. Unfortunately, there are not a lot of hospitals in Ohio that this is their thing. And I know of one clinic in Dayton that does this really well. It's about 6-month wait list. But you can identify symptoms, write them all down, try to get confirmation of maternal substance abuse. Usually there's a genetics appointment, although a pediatrician can do this also. It's just the measurement of the facial features. The measurements are different depending on the child's race. And then you want to bring any other physiological symptoms like being small for their size or hearing issues or whatever else. And that's all for the medical portion of it. And then the neuropsych eval, you want to bring the IEP, ETR, any other psychological reports and get a neuropsych eval done. And then mention the concern of alcohol consumption. So that's how you would get a diagnosis for one of these kids. The rest of what I have is all about like how to help families when they're struggling with this. I'm going to show you one more thing and then I'll go to my contact information. This is what I'm talking about when I'm talking about children being really defensive about their challenges. So if we have a kid in the middle, this was a child a second ago, and this is the gap of what they can't do. And then we interpret that as being willful behavior and we get them in trouble for it. And we do this over and over and over again and we yell at them for what they can't remember, then they're going to be rigidly defensive and they're probably going to be diagnosed with ODD. So if we see something like ODD, we might want to look at the root cause of why a kid is being so defensive. So that is my information and I'm open for questions.